We are live.
Good morning, everybody. I would like to welcome all the delegates who are with us to this webinar. And this webinar is basically on AIOS dry eye webinar, looking beyond symptomatic relief in dry eye is in dry eye management. And we have a galaxy of speakers with us today, and I would be introducing to you the first speaker. The first speaker, as well as my co-moderator, is Dr. Srinivas Rao, who actually needs no introduction. He's the director of Darshan Eye Clinic and Surgical Center, senior consultant ophthalmology, Apollo Hospitals, Chennai, head cornea service at Sunetra Eye Care Center, Kolkata. He's also worked at Shankara Eye Hospital in Coimbatore. He's the honorary associate professor of Chinese University of Hong Kong and visiting professor of Shantou University, PRC. He's conducted numerous instruction courses at the APO, the World Ophthalmology Congress, ASCRS, AO meetings, and several other international meetings. And I think he was one of the first surgeons in our country to do very complex cases, which included limbal stem cell transplants, anterior and posterior lamellar corneal surgeries, autograft pseudoterigem, and also osteoodontokeratoprosthesis, as well as the keratoprosthesis itself, which was pioneered and started by him and Shankar Nitrale. He has numerous publications in the international peer-reviewed journals, and I would request him now to give his talk. Dr. Srinivas Rao.
Thank you, Namrata. Let me just get my screen shared. Okay. Good morning, everyone. I thought I would start today's session by taking a little peek into literature. And this is a painting from the famous poem by Milton, which is Paradise Lost. And I'm sure many of you are aware that this deals with devil's fall from heaven. So the story goes that Satan basically spawns a daughter from his forehead. Her name is Sin. And then he proceeds to have an incestuous relationship with her, from which is born a son, Death. And just to make matters more interesting and more complicated, Death then proceeds to have an incestuous relationship with his quote mother, sister, unquote, Sin herself. So Milton says that these three entities and the various complex relationships that they have between themselves are responsible for most of the evils that mankind faces, and he calls them the unholy Trinity. In the context of today's session, we are going to be talking about the ocular surface, and we know that it's very important for the corneal and conjunctival epithelium to be healthy for us to have comfort and clear vision. And in order to do this, we have the tears and the mucus from the goblet cells and the lacrimal glands, assisted by the oily stuff from the lids and the Meibomean glands. And all of these work together to keep us happy and comfortable. Just like in Milton's poem, we do have an unholy trinity on the ocular surface as well. And they are the dry eye disease, inflammation, and Meibomean gland dysfunction. And these three entities and their complex interrelationships are what result in most of the damage to the ocular surface. And I chose to call them the unholy trinity in the context of today's session. And our purpose is to deal in the next 20 minutes about how we can objectively assess the presence and impact of these elements on the ocular surface and the damage that they produce. Because as Namrata mentioned, the rest of the session deals with corneal regeneration. And in order to regenerate the cornea, we must first understand the degeneration that has set in. Dry eye disease is one of the three most rapidly growing eye problems in the aged and accounts for 1 out of 4 clinic visits to the ophthalmologist in the US. Based on literature, it appears that the prevalence of dry eye disease and Meibomean gland dysfunction is more in elderly Asians. And in addition, with the increasing use of VDTs today, there is an increasing burden of disease in another subset of younger individuals, in addition to these elderly people that we are aware of already. These patients present to us with various symptoms, and when we examine the ocular surface, we come up with various signs, and sometimes these two do not correlate. Therefore, the need for an objective assessment, because we can't depend entirely on the symptoms that the patient tells us alone. However, both are important because our goal is not just to treat his symptoms and make him comfortable, but we also have to do things to keep the ocular surface health maintained. I'm going to start with inflammation, and we know that Celsus gave us the cardinal signs, which were Calor, Dolor, Rubor, and Tumor. And in 1871, Virchow added the laws of function as well. And these are present when you have ocular surface inflammation as well. We see pain, redness, and swelling or edema. Heat is not so commonly seen because of the very small 2.2 square centimeter surface area of the ocular surface, which is exposed to the environment. And the loss of function initially is a fluctuation in vision, but with ongoing damage, we can have permanent vision loss as well. Now, interestingly, if you think about it, inflammation is actually a protective defense mechanism that is designed to protect the tissues that it works in. It is triggered by damage to the living tissues by insults such as infection or injury. And within the first 24 to 48 hours, the innate immune system steps in to help and destroy and remove this inciting agent and to repair the tissue that has been affected. If the symptom persists beyond 48 hours, however, the adaptive immune system is activated, and the chief currency of this system is inflammation. And if it persists, there is a vicious cycle of chronic inflammation, and the repeated attempts at healing that go on result in scarring with all its consequences to the ocular surface. In the context of dry eye, the presence and association of inflammation has been known for more than 40 years now, but it is only recently that we are truly understanding the complex interplay between these structures. That is what I'm going to try and cover first. Based on the DEWS 2 definition, we know that hyperosmolarity and tear film instability are considered to be the primary events that set up all of these changes on the surface. And these can happen either because of a decrease in the secretion of the aqueous tears or from an increased evaporation of the tears from the surface, which is where Meibomean gland dysfunction comes in. And when you have an unstable tear film, the underlying epithelium, which is in close proximity, tends to get affected, and then it produces a response, which is chiefly the production of these stress-associated mitogen-activated protein kinases from the corneal epithelium. These kinases are then able to initiate the production of various inflammatory mediators. These bring in by chemotaxis the leukocytes and the lymphocytes, and the inflammatory cascade then begins. So most of it seems to start with the corneal surface epithelium, which is why it is important to recognize it and the focus today on the corneal epithelial regeneration itself. A variety of conditions can result in these changes. You can have Sjogren's syndrome, other autoimmune conditions, graft versus host disease, or Stevens-Johnson syndrome. These affect the lacrimal glands, which means there is less tear production, and whatever tears are produced tend to be very inflammatory in nature. On the other hand, you can have surface elements like chronic contact lens use, medication toxicity, surgical trauma, or neurotrophy. These affect the nerves, then the afferent arm of the feedback loop is affected and less tears are produced. Even if tears are on the surface, if you have significant Meibomean gland dysfunction, a poor blink rate, chalasis, Parkinsonism, thyroid eye disease, or extensive video display terminal use, there is constant evaporation. And if this is aggravated by adverse temperature, humidity, and airflow, finally the end result is desiccation and hyperosmolarity. And then this sets up and triggers all of the other changes that we shall see. So a variety of events can be happening on the surface to produce these damages. If you have a transient insult, like a toxic medication, and the acute protective inflammatory response is in vogue, if you can get rid of the inflammatory medication, the changes will disappear and you can quell everything very quickly. On the other hand, in dry eye disease, unfortunately, the stimuli, which is tear film hyperosmolarity and the friction-related damage to the ocular surface, tend to persist because you're not able to address the basic dry eye problem itself. And therefore, in time, the adaptive immune response and chronic inflammation come in. And after the initial cascade, a vicious self-perpetuating cycle develops, which can then maintain itself even if you try and remove the initial stimulus. Most of the patients who present to us with moderate dry eye, they have tear disturbance and inflammation coexisting. And the question, therefore, is which came first? If you look at it objectively, if you have epithelial cell damage from a tear problem, this initiates the inflammatory cascade, as I just said. And this inflammation then perpetuates the cascade, and the inflammatory mediators and the cytokines come back and damage the epithelium, the goblet cells, the Meibomean glands, and the nerves. And this results in a further tear film disturbance, and eventually the two cycles will merge. So inflammation can be a cause and a concurrent element that is present in a dry eye disease. If we look at the actual events that happen on the surface, the epithelial cell produces interleukins, tumor necrosis factor, and matrix metalloproteinases. These help in recruitment of T helper cells 1 and 17, and these produce additional mediators like interferon gamma, tumor necrosis factor, and interleukins. And these cytokines are responsible for goblet cell and tear dysfunction, epithelial cell damage. They produce lymphangiogenesis, which makes it easy for these inflammatory mediators to go back and forth between the surface and the immune processing centers. And these are also responsible for the symptom of irritation that patients complain of. When the epithelial system is affected, it also produces corneal envelope precursors, and these are able to induce a keratinization of the Meibomean gland orifices. These get blocked, and this recruits the Meibomean gland dysfunction into this scenario where there's already dry eye disease and inflammation. So essentially, to summarize, the epithelial cell pathway is important because it produces the initial events, the inflammatory mediators. This results in goblet and tear cell dysfunction and dry eye disease. And the epithelial cell pathway is also responsible for recruiting the Meibomean gland dysfunction into this process. So the epithelial cell damage seems to be an early and constant factor in this process that we are talking about. And therefore, it is, again, as I say, important to recognize the presence of damage to the epithelium and to do our best to heal it so that we can try and short circuit some of these bad things that are happening on the ocular surface. We talked about the unholy trinity and their interrelationships. If you have dry eye disease, it produces epithelial damage, which, as I said, the damaged epithelium produces inflammation and then induces Meibomean gland keratinization. If you have inflammation, on the other hand, it worsens epithelial damage, then comes dry eye and Meibomean gland disease. Or if you start with Meibomean gland dysfunction, there is tear film instability, which results in inflammation, epithelial damage. And so all three basically go hand in hand. And if they persist for any length of time, they become one large vicious cycle, which is self-perpetuating, where each feeds off the other, much like in the poem by Milton itself. So you have inflammatory, this is the cycle. You have the dry eye disease cycle. You have the Meibomean gland disease dysfunction. They are all interrelated. So this causes adds on to both of these. This adds on to both of these, and so on. So it is very important to recognize each of these elements and try and treat them as early and as effectively as possible. Because if you leave one behind, it gradually brings in the other two as well. So with all this, the question then is inevitable. Is inflammation going to be always present in dry eye disease? Are we fighting a losing battle? Is it going to just hurt the surface no matter what we do? To answer this, in a recent 2020 paper, McMonnies talked about the need to segregate dry eye risk factors into those that are modifiable, like the environment, where we can try and deal with it, or those that are non-modifiable, like age, where we just have to manage them because they can't be eliminated. By identifying the specific mechanisms driving the dry eye disease in individual patients, we might be able to have a rational approach to the therapy itself. The other way to look at inflammation is to categorize it as surface inflammation, which is present on the surface epithelium, and the deeper inflammation, which is present within the lacrimal gland and the Meibomean glands. If we understand this concept, this may explain why in many patients who come with inflammation, when we start them on treatment with maybe steroids and other agents, in the first week, there is a good response. The patient comes back feeling very happy. And if we don't understand the deeper component, and if either the patient or us stop the therapy very early within a week or 10 days, they quickly come back with a recurrence of all these problems. And that is because of the persistent deeper inflammation in the lacrimal gland and the Meibomean gland. This is a little more difficult to treat. It needs prolonged treatment. We need increasing concentration of the agents that we use and an increasing frequency of use in order to tackle this deeper inflammatory process. In untreated dry eye disease, because of the persistent stimulus, there is a self-perpetuating chronic inflammation. But if you can treat these patients early and correct the tear film instability, which is triggering all this problem, and correct the epithelial damage so the epithelium does not escalate everything, and take care of the inflammation right at the start, you can heal the ocular surface and exit the patient from this one-way street. But you must recognize and treat these things appropriately at the earliest possible time. The other approach to this was described by Rolando et al. In a paper about 3-4 months ago, where they talked about the importance of looking at the patient's symptomatology. If the patient has symptoms only in response to specific events and they occur occasionally, he termed it sporadic. If it is in response to a specific insult but happens little more frequently, he called it intermittent. On the other hand, if there is no specific trigger and patients have symptoms on most days, it is persistent. And if they have it all the time, it is permanent. He said that the importance of recognizing the symptom complex is because in the first two, you can try and exit the patient by paying attention to these factors. But if they have persistent or permanent symptoms in the absence of any specific inciting trigger, it probably means that they've already lost their compensatory mechanism, they've shifted into the vicious cycle, and here treatment is concentrated more on damage control and maintenance of this chronic process. So we talked a lot about inflammation and its importance. So clinically, the relevance, how do we recognize its presence? We know that you have point of care tests like the tear lab for osmolarity, the inflammatory drive for MMP9 levels, and there are other evolving tests for other inflammatory markers. But these are generally not practical for day-to-day use in a general ophthalmology clinic. So clinically, you can look for the presence of ocular surface redness, and especially if it is associated with conjunctival edema, this is a significant sign of inflammation. Studies have shown that if you have staining of the conjunctiva with the lissamine green dye, it concurs with the presence of inflammatory markers and is a very specific and sensitive sign for the presence of inflammation. So also lip cough or lip parallel conjunctival folds, especially in the inferior temporal region. This is because inflammatory MMP9 causes a dissolution of the subconjunctival stroma, produces a loosening of the conjunctiva, and in a dry eye, when there is increased friction during blinking, this loose conjunctiva is thrown into these folds. So these three are the clinical signs that we can look at in these patients. The redness can be just clinically categorized quickly and easily as mild, moderate, or severe based on your semi-quantitative scaling. Or you can use the standard grading scales like the Efron or the CCLRU scale to quantify it. Or you can take a digital approach where you can basically digitize the picture, and the pixels where the color is red can give you a quantifiable score itself. The presence of lissamine green staining on the conjunctiva is important as far as inflammation is concerned, and also documents the extent of epithelial damage. And this is something that is cheap, easy, and inexpensive, and all of us can do it. As far as the tears are concerned, you can measure quantitatively the height of the tear meniscus using an automated device, or clinically, you can use a Schirmer to provide a surrogate measure. The other aspect of tear function is the tear turnover itself. It's not just the production of tears or the quantity or the quality, but also the turnover. And this is done using fluorescein tear clearance test. But again, this is something that's a bit cumbersome, and you don't normally do it in a clinic situation where we limit ourselves to looking at the volume of tears. For Meibomean gland dysfunction, we have to look at the anatomy of the glands, the physiology in terms of the quantity and the quality of the secretion, and the function. Basically it stabilizes the tear film. Therefore, if it is not healthy, then you can get a very short tear breakup time. So in this to assess the glands themselves, you can do this at the slit lamp by fitting the lid and looking at these yellow ridges, and this is a very healthy Meibomean gland structure. Or you could use infrared mammography to see this in greater detail. This is a spring-loaded device devised by Cobb and Blackie to produce a graded amount of pressure on the lid. But in the clinic, you could just as easily do this by using your thumb on the middle third of the lower eyelid and putting firm pressure. The thumb usually encompasses 4 or 5 Meibomean gland orifices. And what we try and look at is how many of these orifices express oil when you push, what is the quantity of the oil, and what is the quality of the oil. And this gives you an idea of the physiology. We can use lipid interferometry to measure the thickness of the lipid on the surface of the tear film to give you an idea of its functionality. Or you could use something like a non-invasive breakup time, which is considered more physiological because you're not adding fluorescein and a solution onto the surface to measure breakup time. But again, this requires the use of a device. So when we talk about objective measures, they're useful, but their evaluation is becoming increasingly complex. Like I said, NIBUT, tear meniscus height, and lipid interferometry all need a sophisticated device, as often does lipid infrared mammography, and look at and grade the redness itself and to get a score. There are devices available which can do all of this and give you a very nice composite report like this. So basically, if this marker is in the red, it is abnormal. If it is in the yellow, it is suspicious. And if it is in the green, it is normal. So it gives you a nice picture. You can tell the patient what is going on. But of course, this comes at a cost. general clinic which may not have access to all this, you can try and do these things instead. You can get a symptom score using the OSDI or the Ocular Surface Disease Index. You can grade the clinic ocular redness clinically, do a fluorescein breakup time, and as long as you do it in a repeatable manner, you do get useful information. And the staining, fluorescein for the cornea and lissamine for the conjunctiva can be very useful. The Schirmer for the tear volume and the Meibomean gland assessment, as I just mentioned, and this will give you a composite picture of the various objective parameters. But no matter you get them automated way or in a clinical way, there is as yet no single gold standard dry eye sign or symptom, although clinical evaluation is possible and efficient. We must be aware of the sensitivity and the specificity of the tests that we use, and that the numbers that you get, there is a significant overlap between the normals and the dry eye patients with regards to these test results. And therefore, if you want to segregate these two categories better, more metrics must be used. Once you have a measure of the mucus, the aqueous, and the lipid performance, you can put them together to say whether the patient is normal, whether he has an aqueous deficiency dry eye, an evaporative dry eye, or a combination of the both. And on top of this, you look for the presence of inflammation, you look for the presence of ocular surface staining, and the various other conditions which I showed you in an earlier slide, which may be present and aggravating the situation on the ocular surface. So these objective tests help us to detect the presence of changes on the ocular surface. They help you in categorizing the type of disease which is present. They help you to document the changes and therefore grade the severity as mild, moderate, or severe for that particular disease. And by knowing the type of disease and the severity, you can rationally choose the therapy for that particular patient. And when they come back after treatment, you can use these objective tests to sequentially monitor the progress of the disease. We spoke about the disconnect between symptoms and signs. So sometimes you may have a patient with extreme symptomatology in whom the Schirmer is normal and there is no fluorescein or lissamine green staining the surface. But if they have an extremely short BUT, they fall into what is called the short BUT dry eye, which the Japanese and the Asia Dry Eye Society are seeing a lot of in their patients, and this may be responsible for a significant patient symptomatology. On the other hand, if you have patient symptoms which are extensive, but you have a normal Schirmer, no staining, and the BUT is also normal, we may be dealing with neuropathic pain, which often happens in a surgically mutilated cornea or a surgically traumatized cornea because of the nerves that are amputated and then they regenerate in an abnormal manner. And I guess we're going to be hearing a lot about this in the next talk because there is talk about corneal regeneration after corneal refractive surgery, which is one of the situations where you may see this. So to basically conclude, the objective tests are important because patient symptoms can vary. There's a bit of a psychogenic component there. Whereas with objective tests, you know what is happening on the surface, and in conjunction with symptoms, you can use these to aid the management of these patients with a disturbed ocular surface. The tests can be done manually or automated. The difference is the time, the cost, the precision, and the fact that the automated tests are generally non-contact with cell. However, staining is something that remains an extremely important process because all it requires is a ₹1 fluorescein strip, and if you have a blue filter and a green filter on your slit lamp, you can use that itself to assess the conjunctiva also without lissamine. And no matter what the disease process that is affecting the surface, no matter what the pathway is, no matter the presence of inflammation, dry eye, or Meibomean gland dysfunction, ultimately the damage to the surface is the final common outcome of these diverse processes, and staining picks up that particular damage based on which you can assess the disease presence, severity, and then the treatment approach that you want to take. We do have point of care tests that are available already and which are still evolving for various markers on the surface, but as yet their role in routine clinical evaluation is unclear because of the cost that is involved with these processes. So that's pretty much what I had to say about my talk. And I'm going to just now have the next talk, which is going to be given by Professor Kim. Professor Mi Kum Kim is from the College of Ophthalmology and Medicine at the Seoul National University. She has a specialty interest in cornea, in corneal regenerative medicine, in ocular immunity, transplantation, dry eyes, and ocular surface disease, and therefore is very eminently suitable for what we're going to be speaking about today. She has extensive publications in very, very prestigious journals like the Journal of Tissue Engineering and Regenerative Medicine, the American Journal of Transplantation, the Journal of Allergy and Clinical Immunology, and of course, the Journal of Korean Medical Science, among many others. She has a clinical and a research interest and therefore is very well suited to present the next talk, which is going to be about corneal regeneration. And I invite Dr. Kim to do her talk now, please. Thank you.
Thank you very much for your kind introduction. And I'm very happy to join your great symposium. I already have my presentation recorded, so I think please start my recorded presentation.
Yes, Professor, doing it right now. Three.
Dear delegate, I'm Meibomean from Seoul National University Hospital. I deeply appreciate the organizing committee for kind invitation. I hope this virtual presentation contribute to your session interesting and India Web Symposium will be successful. And I wish we all together get through this COVID disaster. Today, I'm going to talk about the corneal regeneration in dry eye disease following refractive surgeries. Main topics are as follows. The worldwide epidemiology shows 15 to 30% of DED prevalence. And I was just told that in northern part of India, the prevalence is up to 30%. Usually, DED following refractive surgery is transient. However, about 20% can become chronic DED. The first definition of DED is tear-film disorder with ocular surface damage. The revised definition is similar, but it has newly included neurosensory abnormality and inflammation. Most time of DED lies somewhere between the aqueous deficient and the evaporative. Among the risk factors of DED, corneal refractive surgery is getting popular around the world, and post-refractive DED is one of the common causes. Given the cornea is highly innervated tissue and the tight junction of the epithelial cells is utmost important as a barrier function, the corneal refractive surgery inevitably disturbs the homeostasis of nerve and epithelial cells. The core mechanism of dry eye means at any risk factors decreasing the tear stability causes a vicious cycle between the reduced stability and the epithelial damage through the ocular surface inflammation. As you know, the LASIK directly disrupts the corneal lobes. The suctioning procedure damages the conjunctival goblet cells, and also the oblate shape change per se disturbs the tear film stability. Decreased sensitivity reduces the blink rate, resulting in the Meibomean secretion decreasing and increasing the evaporation. Nerve damage directly reduces the tear secretion. They all together end up with ocular surface damage, making this superficial punctate keratitis and vision worsening. How epithelial cells are damaged in dry eye disease following refractive surgery. The function of hyaluronan is important here. The hyaluronan is important matrix for stromal frame, as well as intercellular space lubricant between the epithelial cells, and also the promoter for wound healing as a provisional matrix for a basement membrane. Epithelial cell can make a small amount of hyaluronan. However, most of hyaluronan is synthesized by stromal keratocyte. When we do LASIK SMILE, stromal keratocyte die in ablating zone and periphery near the ventricle, which is removed in SMILE. Therefore, the hyaluronan synthesis decrease and it affects both wound healing and dry eye. Decreased ECM, including hyaluronan intercellular space, contribute to friction and rigidity between the cells, decreasing the transepithelial pressure dissipation against gravity and against the friction. Also decreasing the intercellular shear because reduce the elasticity. It induced the cell stress and inflammation, leading a vicious cycle of DED. As well, following factors are added to aggravate DED and abnormal wound healing. Nerve-producing cytokines such as nerve growth factor and substance P, which is very important for epithelial cell survival and homeostasis, is also decreasing. With the stromal apoptosis, the epithelial stromal fibroblast interaction is also decreasing, with reduction of adhesion molecules and tight junction molecules and cell survival cytokines. In addition, the eye drops such as steroid induce the epithelial thinning, and preservative in eye drop can also disrupt the transcellular mucin layer. Here you can see the fibroblast conditioned media enhance epithelial cell migration, which is greater than with substance P containing media and the control. That means stromal apoptosis and nerve apoptosis are key factors in the pathogenesis of dry eye disease and delayed epithelial regeneration in post-refractive surgery, along with the secondary effects such as RAS blinking, Meibomean gland dysfunction, and reduced tear secretion. This cross-sectional study shows corneal nerve damage following refractive surgery is long-lasting. SMILE had better nerve preservation and regeneration than LASIK, but neither procedure had recovered the nerve density back to normal, even at 5.5 years. Whereas the morphologic regeneration of the basal corneal nerve started shortly after PRK ablation and was substantially completed within the 30 days later. In contrast to LASIK, the prospective longitudinal study showed nerve density back to preoperative level within 2 years after PRK. Reassembly of a basement membrane and adhesion molecules are rapidly restored in PRK. In vivo confocal microscopy revealed the epithelial morphology, the subbasal and nerve fiber morphology and density, as well as the stromal keratocyte density are very stable up to 20 years of follow-up in PRK patient, which means PRK rapidly restored nerve and stromal cells and very stable to the 20 years. It also corresponds with the recent meta-analysis data with 14 randomized control studies showing significant reduction of tear VUT in LASIK and significant reduction of tear secretion in LASIK than in SMILE and PRK, suggesting less damage of nerve. Taken all together, nerve regeneration, stromal cell repopulation with ECM restoration, including here neuronal and adhesion complex, and tear homeostasis restabilization with growth-promoting cytokines, all affect epithelial cell migration, proliferation, and differentiation after refractive surgery. One study revealed both NGF and omega-3 fatty acid promoted nerve regeneration 8 weeks following a PRK in animal study. We know we don't have the commercially available neuro growth factor, but sometimes the autologous serum have a nerve growth factor. So if you think the wound healing is delayed, and we can apply the autologous serum based on this data. to improve a dry eye outcome in post-refractive surgery. I know some of the drugs is not available in India, but for the scope to improve dry eye outcome in post-refractive surgery, I mentioned all of these drugs. Tear supplement with 0.1 to 0.3 hyaluronic acid, which I prefer, and the corpuscle is kind of a purinated P2 white receptor agonist. That stimulates water and mucin, sometimes ribopimine. This is a mucin replacement drug. Yeah. This one is necessary, and if you combine the anti-inflammatory drug, it's not available right now in India, but maybe in future you can have it. Cephalosporin revealed better refractive outcome. And blinking exercise is very important. I already mentioned it. We have reduced the blinking rate, which results in the secretion of Meibomean gland secretion is decreasing. So encouraging blinking exercise helpful to restore the MGD management. And in severe cases of dry eye, you can apply the contact flog and autologous serum, which contains nerve growth factor. And omega-3 fatty acid may be beneficial to reduce inflammation and to enhance nerve regeneration. Actually, in my real practice, I use the preservative for hyaluronan, decompressor, cyclosporin, and blinking exercise for the post-refractive surgery dry eye. Just switching gear, about the diagnostic parameters, they are very recently advanced with technological development. I think this is mostly covered with talk by the previous speaker, so I'm gonna skip a lot of part. I'm gonna just keep focusing on the staining. Using the corneal topography system and keratometry and interferometry, non-invasive BUT is available and with a comparable sensitivity and specificity to conventional fluorescent BUT. To evaluate the epithelial regeneration, staining pattern measurement is very important. The location and the severity of superficial punctate epithelial defect, which only involves superficial and sometimes wing cell layers, depend on disease. So in post-refractive dry eye disease, combined with the neurotrophic portion and poor blinking, the interpalpebral and or the inferior part of superior punctate keratosis are commonly seen. The staining area is different depending on which dye you use. Fluorescent stained cell deficient site, whereas rose Bengal stained cells that are not covered with mucins, regarded as normal, degenerative, and dead cells. Examine green stains degenerative and dead cells and cell deficient site. For corneal staining, I usually prefer the fluorescent, and for the conjunctival staining, I prefer the Lissamin green. Here, I think the first speaker talked about in detail. The NUI grading and Oxford scale are commonly used in Korea. And I prefer this one because it is scored 1 to 15. So we have very narrow scale of data to examine and to measure the patient with the details. So here I summarize again because it's very important, and I think the hyaluronan is the first choice, and if you have it, then the stimulant and the anti-inflammatory drugs is a second choice, and blinking exercise is important, and it is very easy one, so I think you can always encourage the patient with blinking exercise. To talk about the Hydra, I'm going to give some of the brief introduction of the effect of hair urinal. I know in India you don't have any combined drug, but I don't want to emphasize the combination. This slide is for the effect of hair urinal, because not much data of literature so far of hair urinal alone application. That's why I choose this one to look at the high urinal effect. And combined with the CMC, it improved the visual acuity and increased the tear secretion. Then compared with the CMC alone, it means hair urinal have some effect on improvement of dry eye. This another randomized control study. Also, they combined with hair urinal and decompensor. And this combination also improved the symptom of dryness as well as the visual acuity improvement. So I think the hair urinal have some effect of the tear secretion and the visual improvement. Well, hair urinal has the anti-inflammatory properties, like hair urinal binding CD44 activation is correlated with superior suppressive activity. And hair urinal, this is a receptor for hair urinal. CD44 also limits polymononucleoside infiltration. So hair urinal has anti-inflammatory activity, and hair urinal also holds water and acts as a lubricant. So not only dry eye, but also the arthritis, inflammatory disease, and also dermatology, hair urinal is widely applied. This in vitro efficacy study also showed the water retention with 0.1 hair urinal was significantly higher than CMC or HPMC all the time. And the survival rate of human corneal epithelial was significantly higher, and most times with 0.1 hair urinal than CMC and HPMC. Recent meta-analysis data using 7 randomized control studies, including about 900 eyes of dry eye disease, showed hair urinal and demonstrated improvement of tear secretion here compared to non-hair urinal preparations. But there is no difference about TBUT between the groups. But I know the single animal study or the just homogeneous group study shows TBUT increase when you use the hair urinal. And this meta-analysis includes a different group of study, and this the patients are not homogeneous, very heterogeneous. So sometimes that affects the data. So I think about the TBUT, further investigation should be warranted. And I heard the 0.1 sodium hair urinate named Hydra is new launched in India. Congratulations. I'm going to talk about a little bit more specific about the Hydra. Purified sodium hyaluronate ophthalmic solution is indicated for the dry eye due to environmental condition. It is extracted from rooster cresta and long chain unbranched aminoglycan and has intermediate molecular weight. pH is 6 to 7, isosmotic, and includes C12 bar 0.0015. Unlike the conventional artificial tears, here urinal not only holds up the water and promotes the epithelial healing. I already told you before about the mechanism. When the epithelial cells are defected, the first fibronectin expresses in the deficient site, cell extended in the horizontal direction of fibronectin, and extended cell proliferate and differentiate in a vertical direction. Hyaluronan is a provisional ingredient of basement membrane, and also intercellular space lubricant between the cells. So after hyaluronan extraction, binding with fibronectin increase and cell extend earlier than spontaneous recovery because reducing intercellular friction means less inflammation and less stress. Also, hydride binds to mucin, which restores the tear film stability, decreasing evaporation. About the TBUT, I told you meta-analysis did not show any difference, but I think this single study also showed the effect. So yeah, we should further investigate. Hydride delivered to aqueous layer with intermediate molecular weight, 600 to 1,000 kilodalton, which are most appropriate for ophthalmic topical drugs. Each gram of hyaluronate is able to hold up to 6,000 times its weight of water molecules. This animal study investigated by Dr. Yoon in Korea also supported 0.1 to 0.3 hyaluronan application, increased tear film and decreased ocular staining in dose-dependent manner. Actually, I have a lot of clinical data, but I was told the next speaker will tell about the clinical study, so I skipped all of the clinical study about the 0.1 hyaluronan data. But I think I should mention the preservative because the Hydra includes 0.0015% C12 bar. Here is the data scanning electron microscopic photographs, compare the different ingredient. This one is C12 bark, and this one mixture, bark mixture, and this is C14. Compare with these two, yeah, you see the exfoliative material can be seen in the epithelial cells. Here, this C14, C12 bark did not show any ocular epithelial toxicities. And also, ocular toxicity of C12 bark was not seen up to 39 weeks when it applied to the levid corneal surface, which means the hydra, including the 0.0015 C12 bark, can be applied without ocular toxicity at least 9 months. Final question is how long we should apply hyaluronan for DED following refractive surgery. That depends on how long the corneal stromal remodeling lasts after ablation using excimer. This study presented by day 180. Stromal thickness was almost completely restored. The stromal cell population occurred below the ablation interface by then. You can see the collagen and the stromal nucleus keratocyte. Stromal keratocyte nucleus were normalized by 6 months, and the hyposmos actin and fibronectin. This is provisional molecules for stromal wound healing. Disappears by 6 months, which means stromal wound remodel was completed by 6 months. And it also means epithelial stromal interaction is restored within 6 months with adhesion complex ECM back to normal. And through that, we can think we should apply the hyaluronan at least for 6 months until the completion of stromal wound healing. Here is one of my cases, 26 years old female who underwent LASIK in local clinic. 1 month later, dry eye disease and superficial punctate cataract developed. So she was referred to me, and actually in Korea we have preservative-free hyaluronan. So I applied preservative-free 0.1 hyaluronan every 2 hours for 6 months, and you can see SPK disappeared by then. So wrapping up a key point in post-refractive surgery. DED is very common side effect of refractive surgery and sometimes becoming chronic by 20%. Key concept of corneal epithelial damage and dry eye disease following refractive surgery is that nerve and stromal keratocyte damage. This is first one, and they're accompanied by the ECM decrease. And shape change also contribute to the abnormal wound healing and dry eye disease. Delayed nerve regeneration in DED is largest in LASIK and less in SMILE, at least in PRK. To improve visual and dry eye outcome, we can apply hyaluronic acid to promote wound healing and tear retention. If it is available, you can combine with anti-inflammatory drops and tear stimulant and omega-3 fatty acid. The blinking exercise I definitely recommend. It's very simple one, and you should apply the hyaluronan at least 6 months, 3 months until the completion of stromal wound healing. Thank you very much for your attention.
Thank you so much, Dr. Kim, for that excellent presentation. There were so many insights and so many things which we also, learned from the presentation because of the various studies that you showed. And before we take up any questions, I would request the admin to please play the sponsor's video.
Sorry, I cannot follow you. Please slowly speak again.
Okay. Mr. Bhushan, can we have the video, please?
So next one.
Yeah.
Okay, thank you.
Yes, ma'am.
Can we have the video, please?
Yes.
There is no audio in this.
Are uncomfortable and causes visual dysfunction in patients. This is due to the abnormality in quality, quantity or hydrokinetics of tear drops, leading to the instability of the tear film or damage to the ocular surface. Higher dry has a special macromolecular network structure that provides high moisture. 1 gram of higher dry can combine with 6,000 times its own weight in water. Characteristics of higher dry as a non-Newtonian liquid make it possible to cover the ocular surface evenly with low viscosity while blinking and high viscosity while staring. This provides a unique level of comfort for patients. Higher dry interacts with secretory mucin and transmembrane mucin, which increases its viscosity. Therefore, it can adhere to the surface of the cornea and provide efficient and long-term protection. Meanwhile, higher dry prolongs its residence time on the ocular surface, which makes tear film stable, extends its breakup time, and lubricates the ocular surface longer. The natural healing ability of damaged corneal epithelium consists of 2 physical processes, namely migration and proliferation of epithelial cells. Many ocular surface diseases can destroy the corneal epithelium's integrity, leading to epithelial cell damage and desquamation. Higher dry works in conjunction with fibronectin, which accelerates the extension and migration of corneal epithelial cells and promotes the healing of corneal epithelium damage. Higher dry efficiently improves the barrier function of the corneal epithelium and constructs a healthy ocular surface microenvironment and increases the integrity of the corneal surface cells. Higher dry is a polysaccharide artificial tears eye drop that has a biological activity. The molecular weight of refined hyaluronan and effective constituent of higher dry is in the best range for treating dry eye.
So thank you for that. And now I'll be introducing the next speaker. The next speaker is Dr. Bhaskar Srinivasan, a very good friend of mine who did his MBBS in 1997 from Mumbai University and subsequently did his MS from AFMC in Pune. He completed Cornea and External Disease Fellowship from the world-renowned ophthalmic hospital, the Shankar Nethralaya in Chennai, and then joined there as a consultant. And presently he's working as a senior consultant. And we all know that he's done a huge amount of work on ocular surface disease as well as keratoprosthesis. He's well versed with the various types of lamellar, corneal, and refractive surgeries and has many publications in the field of his interest. He has participated in various national and international conferences and particularly spoken on ocular surface disease, dry eye, keratoprosthesis, chemical injury, and Steven-Johnson syndrome, which are cases actually which very difficult to treat. He is a part of a unique team in Shankar Nethralaya where patients with all kinds of ocular surface disease are treated, whether it is stem cell based treatment or keratoprosthesis. And he's involved in the cornea postgraduate training program of Shankar Nethralaya Hospital as well. And of course, I did not know this to add the lighter side to his personality. He loves to play badminton and is an avid sports enthusiast. So I would now request Dr. Bhaskar to please give his talk, and his talk is on look beyond symptomatic relief.
Thanks, Dr. Nanduta, for the wonderful introduction. I'll just share my slide. Is the slides visible?
Yeah.
So I would like to thank Santan for giving me the opportunity, and I would also like to thank Santan and Bhushan specifically for giving me the slides for this presentation. So we are going to be basically discussing on efforts to look beyond just symptomatic relief in dry eye and what do some of the clinical and preclinical studies tell us. So when you look at dry eye, according to the latest DED guidelines in terms of definition, the most important words are that there is a loss of homeostasis of tear film, there is tear film instability, there is hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities are there. So all these together play a role in making the patient symptomatic and causing changes on the ocular surface. And when you look at classifying dry eye, you would basically broadly categorize them into an aqueous deficient dry eye or an evaporative dry eye. And the aqueous deficiency is further subcategorized as either being a Sjogren's or a non-Sjogren's dry eye. And the MGD is categorized as being caused either because of an intrinsic pathology or an extrinsic cause. There's also another way of classifying dry eye apart from the DED, and this was actually given by the Asia Dry Eye Society, and there they came up with the concept of tear film oriented diagnosis and tear film oriented therapy, where they primarily looked at the stability of the tear film with respect to the tear film breakup and the pattern of breakup. And based on the pattern of tear film breakup and the timing of tear film breakup and the movement of the tear film on the ocular surface, we would be able to categorize what is the component of the tears that is affected, whether it's the mucin which is affected, whether it's the aqueous which is affected, or whether it is the lipid layer which is affected. And based on the primary component which is affected, they came out with an algorithm as to what would be the lubricating drops or what would be the medications that would be given. So when you look at the in general algorithm, when we look at a dry eye treatment pattern, and when we start treating patients, you have environmental strategies which you might need to address. Most of us primarily look at tear film supplementation with artificial tears, and that forms one of the most important arm of our treatment. But as the disease severity increases, you would have to consider tear retention strategies, stimulation strategies, and biological substitutes, along with the role of anti-inflammatory therapy. The DEUCE-1 guideline initially came up with a very good algorithm in terms of the grading of the dry eye and the medications that you would use in each grade. And the DEUCE-2 continues with the same, there's with a few additions. So when somebody is graded with a step 1 dry eye or a level 1 dry eye, you're basically looking at just environmental or dietary modifications or removing or eliminating the offending agents. You're looking at eyelid therapies if there is a little bit of MGD. Step 2 is actually important because this is the time that we would be shifting from probably a preservative lubricating drop to a preservative free lubricating drop. And here is the role for an anti-inflammatory molecule such as cyclosporine. And in fact, if we delay the use of cyclosporine beyond this and it goes to step 3 or step 4, then maybe even cyclosporine would not work. The newer additions today with the advances would be in terms of probably using lipitegrast, even though it's not available as yet in India. Topical chloroquine, we do have available in India, and some of us do use it. But again, there's not much of literature based on its use. Again, in step 2, especially with the advances in Meibomean gland treatment technology, you could probably put in the LipiFlow or the IPL if the MGD is severe. You could look at punctal plugs as temporary measures in step 2. And if it progresses to step 3, you're looking at a permanent occlusion with either a cautery or a permanent plug, or you're looking at therapeutic contact lenses such as the PROS lenses or biological substitutes. And surgical options would be for a step 4 where there's already ocular surface significant damage. So when you come to sodium hyaluronate, a 0.1%, and when you look at the mechanism of action versus some of the other lubricating drops in the market, an artificial tear supplement basically just replaces the water and it washes off whatever debris is there on the ocular surface. Whereas sodium hyaluronate, in addition to replacing the tears, also increases the stability of the tears on the ocular surface, and it has a beneficial effect on the corneal epithelium, and it accelerates epithelial healing. So when you look at what are the evidence, you have either in terms of preclinical evidence and clinical evidence. So when you look at preclinical evidence and you look at cultured rabbit epithelial cells, in cultured isolated rabbit corneas, sodium hyaluronate was shown to facilitate the adhesion and the expansion of the epithelium over a period of time. And when you extrapolate it to rabbit corneas, where you experimentally induce an injury, either with the use of N-heptanol, which preserves the basement membrane, or with the surgical removal of the epithelium where the basement membrane is already damaged. And if you look at a vehicle versus a 0.1% hyaluronate versus a 0.5 or a 0.3% hyaluronate, and look at how the healing happens. And this was basically the study design where they put the medication immediately and then at 2-hourly interval for 4 times, and then the experiment 2 where they started the drops immediately at 2-hour intervals for 4 times and then 2-hourly in the next day. So when we looked at the wound healing response in these rabbit corneas compared to vehicle, the 0.1% sodium hyaluronate stimulated wound healing regardless of the presence or absence of the epithelial basement membrane. But between a 0.1 and a 0.3, the 0.3 facilitated a faster epithelialization if the basement membrane was also damaged. It decreased, so to conclude, sodium hyaluronate decreased the time required for wound closure, and almost within 48 hours, the surface was epithelialized. And this was independent of the molecular weight, but it did depend, like I said, on the concentration of the sodium hyaluronate. So to conclude, when you're looking at an epithelial healing, you're basically looking at 3 steps: a migration of the epithelium, a cell division, proliferation, and a cell differentiation. So very early in the injury phase, sodium hyaluronate does promote healing by facilitating a movement of the epithelium on the surface, and it very quickly reestablishes the epithelial barrier on the bed. And point 1 was effective for mild damage with a relatively intact basement membrane. So when you look at sodium hyaluronate concentration and molecular effect versus the other molecules in terms of chondroitin sulfate, chondroitin, keratin sulfate, the sodium hyaluronate significantly affected the epithelial wound healings as compared to the other molecules. So just to conclude it again, it basically sodium hyaluronate facilitated adhesion and expansion of the epithelium, significantly promoted extension of the epithelial layer as compared to a control group, and helped stimulate wound closure in a dose-dependent manner. So when you look at clinical studies of sodium hyaluronate, so if you look at what is called as the breakup index, which is basically a ratio of the breakup time after installation of the drop versus the breakup time before installation of the drop. The artificial tears as well as sodium hyaluronate initially increased the breakup time significantly, but this effect was more sustained or more long lasting with sodium hyaluronate as compared to a CMC based vehicle. This is a phase 3 study where sodium hyaluronate was compared with a control vehicle, and one eye of the patient was given sodium hyaluronate and the other eye was given the control vehicle. And the evaluations are basically in terms of the subjective symptoms, which were either improved, markedly improved, slightly improved, unchanged, or worsened. The objective findings, which were based on the fluorescein staining at 2 weeks and 4 weeks as compared to the baseline. There was also a questionnaire on the global improvement between both the eyes, which was independently rated, and the overall safety or adverse effects were also noted. So when you look at sodium hyaluronate versus the vehicle group, almost about 50% of the eyes which received sodium hyaluronate showed that the patient said that they felt it was useful or very useful as compared to their pre-drop phase. When you look, and this is just another graphical representation of the same data. When you look at their objective and subjective rates of improvement, also sodium hyaluronate scored much better than the placebo, and this difference was statistically significant. And when you look at objective improvements alone, disregarding the subjective improvements, the difference was also statistically significant. And in fact, the objective parameters were much better as compared to the overall global or when you add the subjective parameters as such, indicating the beneficial effect of the molecule on epithelial healing or epithelial regeneration. As far as safety profiles are concerned, there were a couple of patients who had conjunctival edema or allergic conjunctivitis, but that was not something which was seen very commonly. It was as for any lubricating drop available in the market. So to conclude, based on the combined subjective and objective findings, there was significantly better overall improvement in eyes assigned to the sodium hyaluronate as compared to those treated with the vehicle. The objective improvements were slightly better as compared to just the subjective improvement. This was, again, with hair dry, we are basically worried about the use of a preservative, because we always look at avoiding preservatives, especially when we have to use lubricating drops for a prolonged period of time. And even if you look at the DEUS-2 guideline from level 2, we say you have to use a preservative-free molecule. So when you're looking at hair dry as an option and the presence of BAC is there, so obviously there would be a little bit of concern. So this study looked at the use of preservative-free sodium hyaluronate versus the BAC, which basically has a preservative versus sodium hyaluronate with BAC of about 0.003%, and the dosage was more than 6 times in a day. Again, basically the objects were objective improvement, subjective improvement, and the patient impression along with the side effects. And the side effects in eyes with preservative and without preservative at a concentration of 0.003 was almost similar. So at such a low concentration of BAC in these eyes, it was not making a significant difference to the ocular surface. Again, why is this? It is probably related to the version of BAC. So if you have a BAC C12, the damage to the ocular surface by a BAC C12 is much lesser as compared to a common BAC mix, which causes significant more ocular surface damage, as seen by this scanning electron microscopic images 10 minutes after application of both the drops on a stem cell growth. So if you are looking at a long-term administration and whether this long-term administration of drops with a lower concentration of BAC causes a problem. So we looked at this study, which shows up, this is an in-house data from Santen, which looked at sodium hyaluronate 0.05%, 0.1% and 0.3%. And for the long-term 1-year data, they looked at sodium hyaluronate 0.1% and 0.3%. And again, graded it based on subjective and objective findings. And the overall improvement was seen in almost 53% patients. And most of them had moderate or more improvement. So unlike a standard BAC, the C12 BAC in sodium hyaluronate has less toxic effects. And even after almost about a year, the patients do have an improvement in their symptoms and in the ocular surface status. So compared to conventional BAC, the toxicity of the C12 BAC seems to be much lesser. So in summary, basically sodium hyaluronate addresses both the aqueous phase of the tears because it acts as a lubricant. It holds on the lubricant on it, the tears on it, almost 6,000 times its molecular weight. And it also attaches to the mucin, stabilizing the tear film on the ocular surface. It helps faster epithelialization of the ocular surface, and it stabilizes the epithelial alterations in patients with dry eye. And thus it improves the epithelial damage, and it improves both the subjective and objective signs of patients who have dry eye disease. In addition, with respect to specific corneal wound healing and corneal epithelial regeneration, it seems to be playing an important role. So to a certain extent, post-surgery patients, like what the previous speaker said in terms of post-LASIK or post-cataract surgery, this might be a useful lubricant to use. Thank you.
Thank you so much, Dr. Bhaskar, for explaining so well about sodium hyaluronate and all the various studies. I would now request Dr. Srinivasan to introduce the next speaker. Dr. Srinivasan is there?
Here, we're having a lot of problems with my internet. Just managed to get
I'll
back.
just share the screen. So
yeah,
here it is.
Ajay basically is a very good friend, apart from his qualifications as a wonderful corneal surgeon and ophthalmologist. In fact, he was one of my first mentors in corneal surgery when I was at Shankar Nethralaya, and I was posted with him when he was a consultant there. He was a consultant at Shankar Nethralaya and the cornea services, after which he went to Dallas to work with Dr. James McCulley as a fellow there in cornea, and I was lucky enough to visit with him when he was in Dallas as working under McCulley as well. So Ajay is a nice person. He's got extensive experience in dealing with various problems of the cornea and the ocular surface. So he's going to share with us some interesting case studies where he has used the hyaluronate-based drop system to try and treat the various problems. Dr. Ajay Dave, please. Thank you.
Thank you, Namrata, and thank you, Santen, for today's presence on the screen. From the science to the world of clinic, learn you must. Maybe unlearning is more important. So let me start with my Japanese style of a haiku. Vision gets blurry lid vipers tired, flails flat, teardrops from comb. Now I'm referencing to a rooster. So my first look at the dry eye patient was as an undergraduate at King George's when I watched my professor do a parotid duct transplant for a bone dry eye. The comedy of the post-operative was that the patient would often cry when he was eating his food. I next move on to Shankar Netralaya and had a great time with Srinivas Rao as a colleague and a compatriot, I would say. We both ended up kind of making our own first rose Bengal stains. I also had the opportunity of entering the labs to do my first year osmolarity, and with Dr. Biswas, cytometry for the pre-operative corneas on the corneal transplant with a portable keratometer. Now, two things I realized: that the globe was there and the lids were there. Of course, the lids of these group of subjects would not move, and I would often add lubricants there and move them manually. So that is somewhere in the back, that the lid movement is very critical in your outlook of things. This is a patient of essential blepharospasm, and you can look at the lid movements and your management is going to make a little difference there. I skipped a slide. When you look at the globe, there are subtle findings there. This is the map dot finger dystrophy, and of course, an antecedent presence of dry eye states. Look at a white and dry eye in a frontal view. Now, this is a follow-up patient of episcleritis, and sometimes the findings are right now not on the visible part of your eye. And if you look at the next slides, you'll see that these are present way up in the fornices. So this patient would require long-term management of dry eyes beyond the management of epi's. Now, these, I think I lost. Am I visible? Jayo?
I think the screener is not sharing.
There is a bandwidth issue.
Yes, we've got it now. We've got it. Dr. Ajay, we've got it. You have to unmute yourself. You have to unmute yourself. We can't hear you now.
Dr. Dave, please unmute yourself.
Sunil, please unmute him. Unmute Dr. Dave.
Ma'am,
Am I unmute now?
Again muted. You were unmute for a split of a
Yes.
second.
All good, sir.
Yeah, now it's fine. Now it's fine.
Okay. So when you look at these coleus superior follicles, they are kind of disturbing the contour of the globe. Now, vernal catarrh has been
bandwidth issue there.
Dr. Ajay, if you stop your video, maybe your internet will work better.
And what I losing out again and again.
I think
Dr. Dave, one request to just switch off your camera while you are presenting. That way you will be consuming less bandwidth.
yeah, if you can put off your video, then we can just share the screen and then the bandwidth sharing would decrease. Or else, Sunil, if you can get the presentation on email, maybe you can present it from there and Dr. Dave can talk.
Yes, ma'am, I can.
Yeah, so meanwhile, we can have the next presentation. Dr. Srinivasan, can you please introduce the next speaker?
Okay, if that's the plan, I think we will let Ajay work out his video. Maybe the what Namrata suggested we will try. So then I guess that leaves the last speaker for now, Nikhil. If he's ready, maybe we will ask Nikhil to present. Dr. Nikhil is in practice in Bombay. He's a very well-known corneal surgeon. He deals with all manner of complex tertiary problems in his practice in cornea, in Mumbai, and he has a deep interest in allergies of the ocular surface, particularly with vernal, and he's come up with his own nomograms, which are quite helpful to all people practicing, which try and help us detect the severity and the interventional strategies that we can use. So Nikhil is going to be talking today as well. So I'm going to ask Nikhil to go ahead with his talk while we are waiting for Ajay to get his session sorted out. Nikhil, please. Thank you.
Sir, you are on mute.
Now it's okay.
Yeah, now
Yeah.
Can you hear me?
you have
Yeah.
to just, yes.
Yeah, so, okay, thank you. So I think during this webinar, we've all heard how sodium hyaluronate helps epithelial healing, and I think we all agree that we use it for different types of dry eye cases that we come in a clinical practice because of its properties of healing and water retention and tear film stability. I was wondering whether we could think of and maybe discuss situations of ocular surface disorders where sodium hyaluronate will be beneficial than the other tear substitutes. I must confess that I may not be using it for all these conditions because sometimes it's not in the back of the mind, and that's why I thought I will share some of these situations so that probably we should, think over them and decide whether it would be useful to use these drops in these particular situations. So I thought I'll just look at some of the clinical situations where we can use sodium hyaluronate other than the ones we discussed today, and also see if there is any literature on those specific indications. So I know that most of us treat abrasions by patching the eye, and that means we may not be able to put drops, but sometimes we don't patch the eye if it's traumatic or we feel there is a possibility of some infection, so we would like to treat with antibiotic drops as well. And sometimes when we remove the patch after 24 hours, the epithelium has healed, but probably it is not as healthy as a normal epithelium. So I was wondering whether in these situations, we normally always use an artificial tears as an addition to the antibiotic drops or the ointment that we use, and maybe sodium hyaluronate may be a good option in these patients as it might improve the healing and provide better comfort. And there are some studies which have been done and reported where they had used it for corneal abrasions. And in fact, in one study that I went through, they had mentioned that before they patch the eye, they would put a drop of sodium hyaluronate, and they said that it might be helpful in the epithelial healing once the eye was patched. So I thought maybe this is one, again, situation that we commonly see in our clinics. We use tears, but probably maybe hyaluronate may be a better option in some of these patients. Of course, we discussed that a lot of post-surgical cases like cataract and post-refractive surgery, we would like to use sodium hyaluronate, and there is a lot of data that we saw today. But then I was just wondering, we have several cases where we end up in epithelial defects on the table, and we always like the epithelium to close up quickly because that puts the fear of infection away from our minds. For example, a cross-linking procedure with epithelium off, or when we do a photorefractive keratectomy or a PTK. Pterygium surgery, especially a large pterygium, creates a significant amount of bare area on the corneal surface. And similarly, when we do other ocular surgeries, such as limbal grafts or excisions, or so number of ocular surface surgeries do leave a large bare area on the corneal surface which needs to epithelize. And again, all these patients are treated with artificial tears, whether it's in the back of the mind or not, whether we would like to use sodium hyaluronate or we use just what comes on our thought or on the pen. There have been some data to show that it tends to accelerate the epithelial healing following a PRK. And there is also a study I could find where they've used it after pterygium surgery, and they found that it enhances the epithelial healing process. We know that diabetics have a cornea problem on the ocular surface. Tight junctions are not up to the mark. So there is poor epithelial cell adhesion, a poor barrier function, an increased permeability of the corneal epithelium. Similarly, the hemidesmosomes are probably not functioning as great, and we know that the diabetic epithelium does not adhere well to the Bowman's. The basement membrane itself may be abnormal and thickened because of an increase in the presence of glycation end products. All these factors may predispose the corneal epithelium or the cells to slough off and probably not adhere well to the surface. In addition, we have trophic related problems because we know that there is a decrease in the subbasal nerve density, which itself also contributes to reduced aqueous tear production in diabetics. We know that for various reasons, there may be an increase in the Meibomean gland dysfunction in patients who have diabetes, and there may be an increase in inflammatory markers on the ocular surface in patients with diabetes. So a number of mechanisms might contribute to not only a dry eye process, but also corneal problems that we see. Typically, we also see, for example, when vitrectomies used to be done, the cornea epithelium used to be debrided. And I remember in my postgraduate training, we used to have problems post vitrectomy when the epithelium would not heal, and it used to be a big problem. So in diabetics, again, where there are all these type of problems, we need a drug which can aid epithelial healing. And there have been several articles in literature which have looked at sodium hyaluronate and the corneal epithelial healing in diabetics. in animal as well as in human trials or human patients. These studies have been done which show that they help the corneal epithelial healing and diabetic eye disease. Similarly, we encounter large epithelial defects with probably injury to the basement membrane structures, and severe cases of chemical burns may have extensive damage in addition. Some of the milder cases may just have an epithelial slough off, and we always use lubricants when we give to a patient in addition to all the other treatment that we give for a chemical burn. And we are basically concerned with ocular surface epithelialization, so that helps to protect from further corneal melting and more complications. And I was wondering whether, in addition to all that we use, maybe sodium hyaluronate given 4 to 6 times a day might be a useful addition to the treatment armamentarium. And as I think Bhaskar also mentioned, there have been several studies on corneal burns in animal eyes where they've used sodium hyaluronate, and they found that it helps the healing process, and the epithelial healing has been studied in animal eyes. And also in human trials, there have been some cases where they found that in alkali burns, maybe the corneal epithelialization in with sodium hyaluronate is faster. Similarly, in cornea practice, we also come across several patients who have recurrent corneal erosions where the epithelium tends to break down repeatedly. We have patients where the epithelium fails to heal. Sometimes we have neurotrophic problems, and patients who have limbal stress or limbal problems due to various reasons may have an epithelial breakdown, or the epithelium may not heal, and they may have punctate staining. Again, in some of these patients, maybe we're trying sodium hyaluronate, as we know that in addition to epithelial migration, I found this study which said that it helps the recovery of the hemidesmosomes, which might be an additional advantage in patients where there is a problem at the hemidesmosome level, in addition to the epithelial healing problem. When we do a corneal transplant, we often use sodium hyaluronate during surgery, and it's often that we coat the ocular surface with the residual sodium hyaluronate that is left behind at the end of surgery. And we know that probably it helps protect the corneal surface. Similarly, using sodium hyaluronate drops post-surgery might help to stabilize the corneal epithelium and the corneal healing probably faster than if we use probably other medications. Of course, it is a situation where we know the donor epithelium is going to slough off. We are using a large number of medications and often preservatives on the ocular surface post keratoplasty. The graft surface itself is neurotrophic, and there are often tear film resurfacing issues because the curvature may not be as uniform. So with all these issues, we see clinically that in the first 2 or 3 weeks following a corneal transplant, the graft is clear, but the epithelium is not very healthy, and therefore the patient often is not seeing as well as we would like to, even in the first few weeks. So probably again using a drug which might aid the epithelial healing may be a good option. And there are some studies again in literature which have looked at epithelial healing following a corneal transplant. So basically what I was thinking was that there are several indications in our clinical practice other than the routine dry eye cases where sodium hyaluronate may have an advantage because of its various properties. And I think it's time that probably we look into some of these cases and see whether the drug can help our patients heal better and feel better. Thank you.
Thank you, Nikhil. I think it was covered very well that where sodium hyaluronate would have an additional role and would be more complementary in helping in epithelialization. Bhushan, do you have Dr. Ajay Dave, can we begin with your presentation?
Yeah, sure. I'll start from where I stopped.
Yeah.
The technology helping me this time? Am I audible?
Yeah. Yeah, you are audible. You are audible, Dr.
Am I audible? Okay.
Ajay.
So
Yeah,
moving
now it
on
is
from the, okay,
perfectly
am I
audible.
audible right? Okay.
Yeah.
So these are the post adenoviral keratopathy, which will go long term into Zika syndromes, and they need to be managed accordingly. So depending on the diagnosis, these are the macro diagnoses of NIT and exams we were talking in the past few talks. This is a result of a soft
I think it has gone again. So I think we'll take up the questions if they are there. Dr. Nikhil, Dr. Srinivas Rao, I think there is a question there. How long can sodium hyaluronate be prescribed? Can we prescribe it for 1 whole year?
Bhaskar can answer that.
Yeah, I mean, it depends on the indication for which you are giving it. If it's for a patient with a dry eye, you know that he's going to be continuing the medication for a reasonable period of time. If it is a post-surgery a patient like a post-PRK or a post-LASIK state that you're giving it, then you're probably looking at about 4 months to 6 months of the use of the medication.
So that just as a corollary to that question, maybe I can ask Nikhil. So hyaluronate, are you looking at it, Nikhil, as a tear substitute for routine use, or are you using it as a therapeutic agent for very specific indications, or is it like a generic tear substitute that you would use as a first line, or do you have only specific indications how would you categorize it? Maybe Nikhil can answer that because he was talking about the other conditions as well. Are you there, Nikhil?
Yeah, so basically when we use tear substitutes as say, let's say placebo, or when you have computer vision syndrome, or you're just using it in those situations, probably I would use the other polymers which are available in the market most often. However, when we have a patient either with established dry eye, or we have, as I said, some of these ocular surface pathology, I would definitely try to use and see how the patient is doing with sodium hyaluronate. So I wouldn't say that we should use it in all the cases, but definitely in cases where there is epithelial problem, or there is a established dry eye or ocular surface disease, I think it may have a good role. We should try using it and see how the patient responds.
Thank you. Dr. King, can I ask you about the importance of corneal regeneration, the concept itself in dry eye disease? I know you did talk about it in your talk in the context of refractive surgery, But if you're talking about a standard dry eye disease, non-surgical patient, how important is the concept of corneal regeneration? And it's something new that we are hearing about today. So for the general ophthalmologist, how does he go about looking for evidence of damage, and how does he go about repairing it? If I can ask you to address that.
Yes, yeah. Hyaluronic acid has a property of epithelial wound healing. That means we have some of the epitheliopaths in our dry eye, not only for the post-refractive surgery, but also for the any other environmental or Sjögren's syndrome. In case we have a epitheliopathy, and we can choose the hyaluronan because it has a clearly effect on the epithelial wound healing. So usually my first choice is the hyaluronan for those punctate keratopathy with Sjögren's syndrome or post-refractive surgery, and the other dry eye with epitheliopathy. But without epitheliopathy, and then I choose another drug. Yes.
Thank you. I think that is an extension of what Nikhil also said. Thank you.
Thank you.
There's another question which says that does sodium hyaluronate have any role in treatment of recurrent corneal erosions? So, Nikhil, would you like to answer this?
Yeah,
No,
I think
we can't hear you.
Can't hear.
Now we can. Now we can.
All patients with recurrent corneal are prescribed lubricants. So when they have a very minor episode, which basically just causes a slough of a few cells, and they can have something which leads to an abrasion, which can require 2 or 3 days of erosion happening. All patients typically treat them with lubricants and bedtime ointments, or whenever they sleep, we give them ointment so that there is ocular surface, in addition to using other medications which might heal the basement membrane hemidesmosomes. One could use sometimes mild steroids or MMP inhibitors like oral doxycycline. Mainstay of treatment not only to give symptom relief, but also to prevent the getting dry and therefore getting easily eroded off. We know that sodium hyaluronate has a property by which it sort of sticks to the ocular surface, maybe because of the CD44 receptor, and it sort of stays longer on the ocular surface because of this property, and because of the foiling or the chain nature of the molecule. And therefore, if it stays longer on the corneal epithelial surface, probably it might give them more comfort. That was my thinking. So we need a drug which stays longer, which coats the surface, probably maybe better. Anyway, we have to give some or the other lubricant in these patients. So probably I thought this might be a good reason to try and see how the patient does feel.
I think this question is for Dr. Srinivas Rao, and I think you did highlight on all these things. But Dr. Mohan Raj wants to know what are the indications for how do you decide HPMC or CMC or sodium hyaluronate or glycerine? So many tiers are available. I think it is one of the toughest questions for anyone to answer. So you did allude to it, and if you can just emphasize
basically, the thing is that when we talk about the tear disturbance, we try and decide what component of the tear film is at fault in that particular eye. If you look at it, the tears themselves have a mucin base. You have the membrane-associated mucins, and then the soluble mucins that span the tear film. Then you have the aqueous component, which is the bulk of the tear film, and then you have a lipid layer on the top. So depending on which element you think is most affected, you would want to choose a tear system that tries to replace that. So if you have a mucin deficiency, because in India at the moment we don't have secretagogues that try and improve the mucin secretion like diclofosol or even rebamipide, which was there, which doesn't seem to be available now, you may want to try and use something that mimics the mucin on the surface. So if you have a system which is HP-Guar based, which tries to has a mucomimetic kind of property, you can use that. Hyaluronate also does that to some extent. It has some ability to coat and retain itself on the surface, like Nikhil just mentioned. If it's basically an aqueous tear problem, then you'd like to use one of the more common polymers. You can use a CMC-based system or something like that, because it tries to replace the aqueous there. Whether you use a 0.5% or 1% will obviously depend upon the severity. The 1% tends to be more blurry in terms of vision, but stays longer. So you try and use it for the more severe kinds. Again, we don't have an oil-based system at the moment in India. We don't have an Endura-like product where you have a little bit of oil that supplements the oil deficiency. So there you try and retain the tears more, and then you use a drop that stays longer on the eye, and maybe hyaluronate may be an option there because it holds on water itself, it stays longer on the surface, and then you can consider that. If you have epithelial damage, like they've repeatedly, all the speakers have said, if you have SPK from the dryness and a Sjogren's or something like that, then a hyaluronate-based system is more useful because it has epithelial healing properties. So I don't think there's any fast food kind of answers saying A equals 1, B equals 2. You do have to make the effort to assess the ocular surface, assess the tear film, find out what is going wrong, which component is at fault. And then you can use some rationale to try and use one drop or the other in that particular eye. I think that's the best I can answer that particular question.
So thank you. I think like I said, it's a very tough question, and you really made it like a jigsaw puzzle, how to put the pieces in there. So Dr. Bhaskar, this question is for you. This is from the YouTube. Dr. Smita wants to know what is the role of panthenol in epithelialization?
See, dexpanthenol, all these molecules do have, at least in the lab, definite role that they allow epithelial mobilization on the surface, and that's what the molecule which is available as an ointment did. But in terms of clinical practice, how much it actually makes a difference with respect to the natural healing is a little bit difficult to predict as such.
Dr. Kim, you talked about omega fatty acids, and I think omega fatty acids have, become controversial whether the dietary in the diet, if you take omega fatty acid capsules, does it really make a difference to the dry eye?
Yeah, the recent the study about the omega-3 fatty acids doesn't do any difference the MGD patient, but it's a very huge study, and the indication is very diverse. So very severe cases are included in that study. So I don't think all the eyes have kind of get a beneficial from the omega-3 fatty acid, but omega-3 fatty acid has a definitely anti-inflammatory effect. So I think some kind of neural damage or the anti-inflammation with the MGD, then omega fatty acid may have a beneficial effect. Now in Korea, we have launched some of the clinical study to investigate the omega fatty acid in the MGD patients. We'll see about that. Thank you.
I just wanted to add that there could be situations where you can use 2 lubricants in a given patient. So you could use hyaluronate maybe 4 times, and you could supplement it with another lubricant maybe more number of times in a day. So I think we need to be, it doesn't mean that we need to use one drug for for a patient. So we could combine 2 lubricants in a given patient so that we have the additional benefit of both the molecules on the ocular surface. We must be prepared for trying such combinations.
Dr. Bhaskar, there's this question for you which says that how will you predict pre-operatively whether the patient is going to have after LASIK neurological dry eye?
No way you can predict in terms of a neurological dry eye, but your pre-op LASIK assessment will pick up borderline dry eyes. So you do a Schirmer's, do your staining of these patients pre-operatively to make sure that they're fine. Post-contact lens wearers, it might, and if you have the access to, might make sense to actually look at their Meibomean glands to check what their Meibomean gland status is. Correct the ocular surface first before you end up doing your laser refractive procedure. In terms of a pure neuropathic patients or a neurotrophic dry eye post-operatively, which causes the patient discomfort and pain, that's been in a very small subset of patients where they've then found out that there's been associated vitamin D deficiency, or it's been because of a phantom amputation kind of a thing, where the nerve stubs are seen as stubs in the confocal microscopy, which will take longer for it to heal. I mean, that's not something that you can predict who will develop those kind of neuropathic pain post-operatively. But a prior assessment in the preoperative state goes a long way in not having too much of a issue in the post-operative stage.
So I think these were the questions that we had for dry eye. If there are any questions, Dr. Srinivas Rao, if you would want to.
No, I
Unfortunately,
think that's
we
pretty
don't
much
have
covered most.
yeah, diclofosol is not available. That is the only thing. Another question is that are there any mucomimetic drugs which are available, which can be given?
It is not available here, right? I mean, repipamide was available for some time, but most patients felt a little bit of burning and stinging. But I'm not sure if it's available right now.
No, I think both the brands are not freely available, at least down in South India where we live. So I don't know about the North.
Yeah, no,
They're off the market now.
they are not available. So, Dr. Ajay Dave, if your presentation is ready, we can share screen, please. Yes, it is now looks okay. Yes. Yes.
Doesn't go.
It has gone. It has gone. Now we can go to the slideshow.
Slideshow. Slideshow.
One sec.
Yes, and then perfect. Perfect.
Okay, back with the challenge of technology. So let's come back to this. Do we have to define a dry eyes? It's a confounding thing both for the patients and the physicians. Both DEWS and the Asian Dry Eye Societies kind of looked at various parts to put it into some sort of definition. The word itself, dry eye, is very confounding. So my look at it in the last few days was two words, one from Latin oculum sicco, and the more phonetically close is from our own Sanskrit, which is darya. So for the patient, is it really a wastebasket diagnosis? They remain confused with our utterance of this word. We have looked at the importance of fluorescein stain and where to look in the superior bulbar conjunctiva. And right in the center of this pupillary area, the coalesced punctate epithelial keratitis also confound the patient with a diminished visions. Now, let us look at the newer technology and how it changes your ideas. Now, this gentleman, which we are looking at, has a fairly moderate drop in the lipid layer thickness. But look at the partial blink rates, it's fairly down. And this is what is going to create the symptomology in this group of patients. Okay, so the incomplete blink on a rapid shots of the same, you see the two lids are not touching each other. Let us look at an extremely slow blink rate with a very healthy tear film. The Meibomean gland population looks good. The average thickness is also in a fair zone. But look at the blink rates in 20 seconds, practically 0 in one eye and about 2. And both of these are also incomplete. So look at a Meibomean gland disorder patient with a chalky white interferometry, extremely low lipid layer thickness, and the blink rates are nearly 100% partial. So which means if the lids are not efficiently moving, whatever the quality of your tear film is going to leave it dry. And the same patient, when you look at in a rapid sequence photography, then this is where the newer technology help you understand and change your ideas of what you're looking at. A contact lens user who's symptomatically dry, when you look at the lipid layer thickness, absolutely low. And this technology gives you something incredible in the amount of nanometers of lipid layer thickness. The partial blinks again are extremely high and a fairly good blink rate over here. So this patient is going to be doubly dry because of the presence of contact lens inside and a low blink rate. Contact lens user again, where there are absolutely no symptoms. And here you see some fall in the Meibomean glands in the upper lids, but look at the lipid layer thickness. They are fairly low. The blink rate again is definitely on the very low side, and the partial blink, of course, are absolutely near 100%. But in spite of all the signs which are coming in this technology, the patient is showing no symptoms whatsoever. Look at another gentleman who is a medical doctor. Here he is scoring completely 100% on the signage. The low Meibomean gland score, there is a very low layer of lipid layer thickness over here. The blink rate is absolutely nothing, and almost all of them, 100% of them are partial, which means incomplete blink rate. So these patients are supposedly symptomatically dry, and yet in spite of the complete, on the sign side, you see no symptoms whatsoever professed by the patient. And if you tell them dry, they are not listening to you. And finally, let me come to this 13-year-old child who went through various clinics for a blurred vision. Everyone would refract, and definitely there was no answer to it. When I sent the patient's mother outside, we checked out his history of screen time, and it clearly exceeded 10 hours on the screen. And this is where he's getting an extremely challenged lipid layer, which means his tear film is absolutely unstable. Of course, why and where he was getting blurred was with the reason that he was into rifle shooting. And whenever he tended to stare at the target, after some time, the breakup time would of course reflect and the target was blurred. So understanding his situation, we put him onto lubricants, and voila, after a few months, that's how long it would take, because his partial blinks are still there, but his blink rate is very efficient and he would score very good recovery. So coming back to sometimes when your diagnoses are staring at you, this is a very efficiently done phacoemulsification, and the patient was referred for a odd looking pterygium. And when you look at it, his fornices are kind of zipping up, both in the lower and look at the upper, the symblepharons are coming in. These are the cases of ocular cicatricial pemphigoid. And if you look at it on the other eyes, the story is being foretold that it's a zipped up post-ocular cicatricial pemphigoid. So as we close, I would say we have to have a clever use of technology and a clever arm of therapeutics to complete our management of dry eyes. Thank you very much for your kind attention.
Thank you so much, Dr. Ajay Dave, for a very nice presentation. And I think there's just one question that we have received, one more, and I think I would ask Dr. Kim to answer this. What are the newer drugs that you think would be there to manage the dry eye apart from sodium hyaluronate? I think everybody can take a call on this.
You mean what kind of type dry eye? Be more specific.
For what are the newer drugs generally in both kinds of dry eye, whether it is evaporative or it is, of course, both will have different types, but what do you think is going to be?
Newer, but not now. Okay, yeah, I think two type of dry drugs can be available. So, one is the anti-inflammatory. So, we have a lot of anti-inflammatory drugs, including cyclosporine and ICAM inhibitor. But I think the TSG6 molecule is also one of the fancy candidate to inhibit the to inhibit inflammation. And it is also working on the CD44 hyaluronate receptor. So working on some of the epithelium in the healing. And the other drug is kind of neuro nerve growth factor related drug. I hope would be developed in the future, because right now we don't have, so we just use some of the autologous serum to replace it. And in skin diabetic food, we have a topical nerve growth factor. So if you modify some of the ingredient to be suitable for the eye drops, then we think neurotrophic portion can be treatable with a neuro drug.
Okay. So Dr. Srinivas, would you like to sum up?
I think we've had a fairly good session. I think about the various options that we have to try and diagnose the things that are going wrong with the surface, the new tools which Ajay was showing us, and the way we have to. I think we have to learn to look at these patients slightly differently. The conventional thinking that symptoms, dry eye, teardrops, I think has to change and evolve to a slightly more holistic approach. So we've heard about the ways we can look at it objectively. I talked about the various tests that we can do. Ajay shared with us some of the newer tests, the data they are providing. And we saw data about how hyaluronate-based systems can be helpful, particularly in certain specific conditions, from what Bhaskar and Nikhil shared. And from Dr. Key's talk, we have understood about the importance of the neuro part of it, the damage that we're creating to the surface, the contour changes that we're creating with LASIK, and the various options that we have and how each of them is different, PRK, the LASIK, and the SMILE, and how we can adapt to that depending on the situation that the patient presents to us with. And then, of course, the various treatment challenges that we're trying to deal with. So I think all in all, as far as the corneal regeneration concept, which is what this particular symposium was intended to address, I think we've had a good session. I think the importance of the corneal staining, which is a very cheap, very simple, inexpensive test that we can do before we go on to all these other sophisticated options, which cost a lot capitally to purchase, and then each time when we do it. The staining, I think, is very important, because ultimately, no matter what all we've been talking about, it reflects finally in ocular surface damage, and that is what we're trying to treat. So I think the importance of staining we should re-emphasize, particularly in India, where access to these sophisticated devices is sometimes hard to avail. So if more people can stain and look at the staining in a more critical manner and look at the area, the extent, and so on, I think we will be one step better off in managing these difficult patients.
So I think there is a feedback form which has been generated, and survey link on the Facebook as well as the AIOS platform. So please do submit your feedback on that survey link. And I think with this, we would wind up the session, and we would like to thank all the speakers who were here, who spared their valuable time. Dr. Kim, Dr. Ajay Dave, Dr. Bhaskar, and Dr. Nikhil Gokhale, as well as all the people who are watching it on YouTube, Facebook, as well as on the platform. And we hope we've been able to answer all the questions, and would like to thank my co-moderator, Dr. Srinivas Rao, and Santan for organizing this webinar, and also the audio-visual team, which is at the back, Mr. Kripal Rana and Mr. Sunil, for organizing this. So thank you, everyone, and see you again on another webinar.
Thank you.
Thank you.
Thank you. Bye-bye. Have a
Bye.
good Sunday, everybody.